All right, so as Chair Foster said, we are here today for the staff analysis and potential vote for 3 different Medicare-only ACOs, Lore Health, Vitalize Health KS25, and Aledade Accountable Care 205. So we'll start with a brief introduction, and then we will go ACO budget review, and then potential vote, 1 ACO at a time. So as far as the timeline for this process, last week we were here, we heard from all 3 ACOs for their hearings. Today we're here for the staff analysis and presentation and a potential vote. And I wanted to flag that in case the board needed more time, we do have December 4th earmarked for another date for a potential vote. As far as public comment, no comment has been received to date on any of these ACOs budgets. I'm going to pass it over to Mark Hengsler, our staff attorney, to walk us through the legal side of the budget review process.
Hey, everybody. I'll do a recap of what we did before the ACOs presented on the 13th. And it's just a couple slides, so I'll read through it again. Starting point is that the ACO budget review process is guided by 18 VSA 9382B. The ACOs that we're talking about today are ACOs with fewer than 10,000 attributed lives projected to exist in Vermont for FY25. And that means that the board, rather than considering all of the criteria in statute, has authority to elect the budget criteria that it deems appropriate, considering the size and scope of the ACO. ACOs have the burden of proof in justifying their proposed budgets to the board and deciding whether to approve or modify a proposed budget of an ACO, such as those we're talking about today. The board takes into consideration benchmarks, the criteria that it deems appropriate at 9382B1, the elements of the ACO's payer-specific programs, and any requirements at 18 VSA 9551 or the Vermont APM agreement, and then any other issues at the discretion of the board. With that in mind, staff do have a recommendation as to what parts of statute the board should be looking at for consideration. These are the same criteria that staff recommended and that the board reviewed last year. And I'll just go through these quickly. 1, information regarding utilization of the healthcare services delivered by healthcare providers participating in the ACO and the effects of care models on appropriate utilization, including the provision of innovative services. 2, the character, competence, fiscal responsibility, and soundness of the ACO and its principles. 3, any reports from professional review organizations. 4, the ACO's efforts to prevent duplication of high-quality services being provided efficiently and effectively by existing community-based providers in the same geographic area, as well as its integration of efforts with the Blueprint for Health. Next slide, please. 5, public comment. 6, information gathered from meetings with the ACO to review and discuss its proposed budget. 7, information on the ACO's administrative costs as defined by the board. 8, the extent to which the ACO makes its costs transparent and easy to understand so that patients are aware of the costs of the healthcare services they receive. And 9, the extent to which the ACO provides resources to primary care practices to ensure that care coordination and community services, such as mental health and substance use disorder counseling that are provided by community health teams, are available to patients without imposing unreasonable burdens on primary care providers or on ACO member organizations.
Great, thanks, Mark. I wanted to take the time to go over this flow chart since all 3 ACOs this year are Medicare Shared Savings Program ACOs. I thought it would be good to review how funds flow in this model. So you see CMS at the top, and then you have this blue arrow that goes straight down to providers, and it's fee for service. So this is not an ACO model where the payment mechanism is really different from what providers traditionally are used to. They file claims, CMS adjudicates and then reimburses them for those claims for those services. Where the ACO comes in is they have a contract with CMS, and the ACO has a separate contract with providers. And CMS sets a benchmark, and it's a target rate of spending for the ACO network as a whole. And if those fee-for-service claims come in under what that benchmark is, there is shared savings. And if the provider's claims go over that benchmark, then there is shared losses. And of course, there is a quality component to that, and there is quite a bit of complexity with how the benchmark is determined. So then this is where the ACO really comes in. When there are shared savings, CMS will pay a portion of those savings to the ACO, and then depending on how the contract between the ACO and the provider works, some of those share savings may trickle down to providers. And likewise with losses, the ACO must reimburse CMS for any losses or a portion of those losses, and then dependent upon the contract between the ACO and the providers may have to reimburse the ACO for a portion of losses. And then there is another arrow that goes from the ACO to beneficiaries. There are some ACOs that offer incentives directly to beneficiaries that don't necessarily flow through the provider network. So let's start with Lohr Health ACO and their FY25 budget. This is their third program year and their third year here in Vermont. They are participating in the enhanced track, which is one of the it's the highest risk track as a part of the MSSP. So you can see that the shared savings rate is up to 75%, goes to the ACO, whereas the 25% will be retained by CMS. But there is a cap on that. That cap is 20% of the benchmark. And then shared losses, it depends on the quality performance of the ACO, but it's anywhere from 40 to 75% of the total losses need to go back to CMS, but there is a cap on that as well of 15% of the benchmark expenditures. In the case of Lohr Health, there is a minimum savings loss rate of 0.5%, and that really does depend on the specific ACO and its size. So the provider network of Lohr Health here in Vermont, their participating practice is Springfield Medical Care Systems, also known as North Star Health, which is an FQHC with several different locations right along the New Hampshire border. That means that some of the lives attributed may be New Hampshire residents, and it isn't really possible for the ACO to piece that out. This particular provider is pretty deeply engaged in Lohr itself. Two of their providers sit on Lohr's governing body. And Lohr has providers in 4 different states for 2025, which has decreased by 1 each year. So let's look at their financials. Because Lohr has been in practice and operations since 2023. We do have 2023 actuals from CMS. That data was released fairly recently, so we can look at their performance here in Vermont. They ended up with about 3,100 attributed lives through their Vermont provider. The annual beneficiary expenditures were about $9,500 per beneficiary, which works out to an expenditure amount of almost $30 million. So that's not truly a benchmark, as the label says. That's really what the expenditures were. And then as far as shared savings and losses, we have that amount ACO wide. So it's not just Vermont providers, it's providers in the other, I think there are 6 states in total for 2023. So as a whole, they experienced a loss of 0.26%, but we mentioned that minimum shared savings, shared loss rate previously. It's under that cap, so essentially no money was transferred to or from the ACO with CMS. And then 24 projected, they're looking at a little bit of an uptick in attribution and a small increase in utilization expenditures per beneficiary with 9,750, which works out to $35.1 million. They are anticipating a 1% shared savings experience for FY24. And then for FY25, they are budgeting 3,600 lives with about a $10,000 per beneficiary expenditure here in Vermont. And that the math there works out to about $36.72 million. And they are anticipating, again, a 1% shared savings rate. The bottom part of this chart just kind of spells out what happens globally if there's shared savings. You put the percentage of that savings against their benchmark. You put in their quality performance, and then you subtract the CMS share of those savings. The shared losses works exactly the same. So because we have 2023 data for LOR, I wanted to share this, and there is a link to the data set down there on the slide if anybody's interested in digging in. So LOR experienced a quality score of 67.76% ACO-wide, and the median MSSP in 2023 experienced an 83.07% quality score. And then we looked at another cohort, a median MSSP in their initial performance year. Because LOR was in their initial performance year, I felt like it was good to look at those ACOs are just getting off the ground, and their quality score was 80.4%. As far as shared savings and losses, the financial side of this, as we said, LOR experienced a small loss. The median MSSP was 3.65% savings, and those brand new MSSPs in 2023 experienced a 2.89% shared savings. And I wanted to share this. We had included a budget order condition that LOR Health report their financial performance, their shared savings and losses segmented for Vermont. But that's really, we've come to learn, not possible given the fact that ACOs are not provided with a benchmark that can be segmented in any way. Their benchmark truly represents the entire network, and there's no way to piece out the Vermont portion of that benchmark. So while they know what their expenditures were, they have no truly accurate target to which to measure that against here in Vermont. So we can look at what they thought, what they were projecting would happen when they submitted their budget to us back for their FY23 budget. They were projecting per beneficiary per year spending in Vermont would be about $9,900, and they were expecting a 5% savings rate. The actual results, the expenditures came in lower here in Vermont at $9,700. And as we said, ACO-wide, they experienced a small loss. So LOR Health's model of care, they're really focused on the practice of lifestyle medicine to enable Medicare beneficiaries to take charge of improving their own health. They also offer in-kind incentives that help beneficiaries manage and prevent chronic conditions and aim to narrow health equity gaps. Their model does include the use of a beneficiary-facing mobile app, which more recently has introduced an AI chatbot called LORBot. Patients can ask health questions and receive solution-focused brief therapy. It does not, is my understanding, it does not provide medical advice. So here's some proposed conditions for LOR Health's FY25 budget. I'll read through each one. So LOR Health shall provide to the Green Mountain Care Board LOR Health's MSSP quality reporting segmented for Vermont with appropriate restrictions to protect patient confidentiality. This is a standing budget order condition. This would be the third year that we would see that in their budget order. Second one, following 3 performance years in Vermont, LOR Health shall provide to GMCB reporting for those years on GMCB's specified metrics, which may include categories of inpatient medical, inpatient surgical, emergency department, professional office visits, ambulatory sensitive admissions, and any other additional metrics. GMCB's Health Policy Project Director is delegated responsibility to develop templates and metrics and set deadlines for this reporting. This is a carryover from last year, so that did appear in their FY24 budget order. The third is a new one for this year. Within 14 days of receipt, Lohr Health shall provide the GMCB and the Office of the Healthcare Advocate a copy of any pre-termination notice from CMS, including but not limited to a warning regarding non-compliance with shared savings program requirements, a request for corrective action plan, or a notice of special monitoring plan. Lohr Health shall additionally provide any follow-up communications from the ACO and CMS regarding the pre-termination action at the discretion of the GMCB and with authority delegated to GMCB's Health Policy Project Director. Fourth, this is another new one. Within 14 days of receipt, Lohr Health shall provide the GMCB and Office of the Healthcare Advocate notice of any legal action taken against the ACO or its parent company. Lohr Health shall additionally provide any additional information at the discretion of the GMCB and with authority delegated to GMCB's Health Policy Project Director. And the final one is just this placeholder that the GMCB may make additional orders as necessary. And I did want to note the omission of one, or the removal of one budget order condition, which was around requiring Lohr Health to report any consumer complaints. It's not that we don't want to collect that. It's that that appears as part of the budget guidance. And so we will collect that information on an annual basis as part of the budget submission. And we didn't feel as though it needed to be called out specifically as a budget order condition. So those are what we are proposing, and here is some motion language. Mark, I don't know if you want to read it for the board, and then we can take up board discussion.
No need to read it.
Okay. Back to you, Chair Foster.
Thank you. I will actually go ahead and make the motion and then have board discussion and public comment. I approve the motion, or I support the motion. So I move that the GMCB approve Lohr Health ACO LLC's fiscal year 25 budget as submitted, subject to the proposed conditions reviewed by the board today.
Second.
I have no comments or questions. Any other board members?
I just had a couple quick questions. So on the slide with the shared savings and losses, there's the performance payment limit and the loss sharing limit of 20% and 15%. So when we look at, say, a different ACO model like the one OneCare is in, is that equivalent to their 3% upside and downside risk?
That's how I would think of it, as like a risk corridor.
Okay. So not the 75%, but the 20% upside, 15% downside would be kind of equivalent to the, okay.
Correct.
And then the other question I had, there was the $9,900 projected, but it was 9706 was the spend in Vermont. So is that, but I guess I'm trying to understand, does that mean that there was a savings of that amount, that $194, or is that not?
It would be, that's a great question. And we really tried to work our way back to what would be an accurate benchmark for Vermont, but because of the complexity, these claims have not been truncated, they have not been risk adjusted. I think this can give you a ballpark. I would be very cautious to make any sort of assumptions further than what is exactly on this slide.
Okay. All right. Thanks.
Seeing no other comment from the board, I'll open up to public comment. And seeing none, I'll take a vote. All in favor of the motion, please say aye.
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 Aye. And the motion carries and the budget is approved. Thank you very much, Michelle.
Great. Thank you. We will move along to Vitalize Health KS 25. So Vitalize is another MSSP ACO. It will be their first year here in Vermont and their second year as an ACO overall. So this probably rings a bell. We have Vitalize Health 9, which is an ACO REACH model, which is currently operating in Vermont. It is its first and final year. And so this new MSSP ACO, it's on track E, which is a lower risk track. So the shared upside is 50-50 with ACO and CMS, with the cap of that upside shared savings is 10% of the benchmark. The shared loss rate is 30% back to CMS, with an additional cap on losses, 8% of the ACO participant revenue at capped at the 4% of an updated benchmark. And the minimum savings loss rate is confidential for Vitalize. So their provider network, they are partnering with Five Town Health Alliance, which is in Bristol, and Little Rivers Healthcare in Bradford. They have attributed lives in 16 different states, and so Vermont represents about 6% of their lives ACO-wide. Vitalize Health, the parent organization, is a multi-state organization operating numerous ACOs in many states. And so as mentioned, both of these practices going into this MSSP ACO are currently in Vitalize Health 9, that ACO REACH. So as far as their financials are concerned, they are estimating about 1,700 attributed lives between those two practices, with an annual beneficiary spend of nearly $12,000, and which works out to $19.65 million. And then the same way as described for LORE, the shared savings percentage against the benchmark with a quality performance score minus what CMS withholds, that's what the shared savings experience is. And then Vitalize has shared with us that practices do not have any downside risk with Vitalize. It is calculated the same way as previously discussed, but wanted to share that the ACO is on the hook for any downside risk, and that providers are really shielded from that. Vitalize's model of care, the way that they described it to the board was they take care of the providers so that the providers can take care of their patients. They help with administrative tasks. They offer evidence-based insights to providers. They assist with any clinical outreach efforts, and they really, all their work is really data-driven. They prioritize annual wellness visits, inpatient follow-up, and emergency department follow-up work among their providers. Here are their proposed conditions. I will read through each one. Vitalize shall provide to GMCB Vitalize's MSSP quality reporting segmented for Vermont with appropriate restrictions to protect patient confidentiality. Second, following 3 performance years in Vermont, Vitalize shall provide to GMCB reporting for those years on GMCB specified metrics, which may include the categories of inpatient medical, inpatient surgical, emergency department, professional office visits, ambulatory sensitive admissions, and any additional metrics. GMCB staff is delegated responsibility to develop templates and metrics and set deadlines for this reporting. The third one, within 14 days of receipt, Vitalize shall provide the GMCB and the Office of the Healthcare Advocate a copy of any pre-termination notice from CMS, including but not limited to a warning regarding noncompliance with shared savings program requirements, a request for corrective action plan, or a notice of special monitoring plan. Vitalize shall additionally provide any follow-up communications from the ACO and CMS regarding the pre-termination action at the discretion of the GMCB, with the authority delegated to GMCB's Health Policy Project Director. And I'll just mention specifically with this condition, I'm using the name Vitalize, which is, Vitalize is the parent company, but with this one, the intent would be, and probably we would make sure the language was really clear, that we're interested in Vitalize KS25 in particular. Number 4, Within 14 days, Vitalize shall provide the GMCB and Office of the Healthcare Advocate notice of any legal action taken against the ACO or its parent company. Vitalize shall additionally provide any additional information at the discretion of the GMCB and with authority delegated to GMCB's Health Policy Project Director. And then you have your standard one at the end there saying that the board may make further orders as necessary. And here is the suggested motion language for Vitalize Health KS 25.
Thank you. I'll do the same process because I support the motion, so I'll make it and then we'll have comment and questions from the board if there's a second. So I move that the GMCB approve Vitalize Health KS 25 LLC's fiscal year 25 budget is submitted, subject to the proposed conditions reviewed by the board today.
Second.
And board discussion or questions for staff?
I just have one quick question. Sorry to be the one slowing things down here. Can you go back to the one slide back, I believe. So on this one, on condition 2, are we saying that this is for the parent company Vitalize as the 3-year time frame, such that Vitalize, the first Vitalize ACO counts as year 1, then this KS 25 would be year 2, such that after the 3rd year of Vitalize's involvement in the state, this condition would require reporting?
That's a very good.
And then on the next one, we're saying Vitalize KS 25. I believe, is that
right? That's as far as number 2 is concerned, I think that's a really good question. If the board feels strongly one way or the other, we could certainly clean up that language. I think that there would be some conversation with Vitalize as a whole, as a parent company, to just make sure that it would be, mostly because they're different ACO models, would the reporting between the two models be, congruent in that, there's not one year where, well, we have this data, but for the next year we don't because it's a different model and different reporting from CMS. So I would want to dig into that further if you wanted to say Vitalize as a whole, no matter which ACOs they have here in Vermont, if Vitalize has a presence with any of their ACOs, we're looking at 3 years.
right? And so the challenge with that is that you're blending multiple ACOs together.
Potentially, yes. In this case, you would be. And I am not quite as up to speed with the details about what kind of data they can get between what the differences are, if there are differences.
Yeah. Okay.
Just for language clarity, I'll jump in and say that throughout the proposed conditions, Vitalize refers to KS 25 and parent company is explicitly stated in item 4. So okay. If the board wanted to change to any of this, the language we'd use to talk about Vitalize at the top level is parent company in this language.
Okay, so in section proposed condition 2, this would be Vitalize KS 25. Vitalize means Vitalize KS 25 here.
Correct.
Okay. All right. I'm okay with that. So.
Okay.
I just want to make sure I understand what we're asking of them. So we're conditioning this budget on.
Any other board member comment or questions? And any public comment? Hearing none, all in favor of the motion, please say aye.
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 Aye, and the motion carries unanimously. Thank you, Michelle. I think next is Aledade, and that will be the last substantive agenda item for today. Is that right? Yeah.
Correct.
Okay. So I will abstain from this one, and I will turn it over to Member Walsh to act as chair for the remainder of the meeting. And thank you very much, Michelle. Member
Thank
Walsh,
you.
I'll turn it to you.
Thank you, Chair Foster. Let's keep going, Michelle. Thank you.
Okay, great. So next we have Aledade Accountable Care 205. 2025 will be Aledade's first year here in Vermont and second performance year with this specific ACO. Like Laura, they are part of the MSSP Enhanced track. I'm not going to go through the risk arrangement again, but I will flag that Aledade does have a minimum savings loss rate of 0%. So any sort of minute shared savings or losses, money will be exchanging hands. Aledade is partnering with the Notch up in Richford in Franklin County. They will operate in 6 different states, mostly here in New England, and they have expressed the desire to expand their network in Vermont. Almost 15% of their attributed lives are with this one practice for 25. Aledade itself as a parent company is a multi-state organization with 56 different ACOs operating in 45 states. Here are the financials for Aledade. They are anticipating about 4,200 lives with an annual beneficiary expenditure of $13,605, which works out to overall a $57.7 million spend. And much like the previous ACOs, the shared savings works the same. And with Aledade shared losses, again, providers have zero responsibility for any losses that are incurred at the ACO level. Aledade's model of care. So they work to help their providers prioritize annual wellness visits and transitional care management. They really utilize those admission discharge transfer feeds to make sure that their primary care providers are checking in with their patients after hospital discharge to reduce the number of readmissions. And they did share that no beneficiary enhancements or payment waivers were offered for 2025. Here's a list of proposed conditions. They will be pretty familiar. First being, and again, this is Aledade specifically, just the language note, Aledade meaning specifically Aledade Accountable Care 205. Aledade shall provide to GMCB Aledade's MSSP quality reporting segmented for Vermont with appropriate restrictions to protect patient confidentiality. 2, provide following 3 performance years in Vermont, Aledade shall provide to GMCB reporting for those years on GMCB specified metrics, which may include the categories of inpatient medical, inpatient surgical, emergency department, professional office visits, ambulatory sensitive admissions, and any additional metrics. GMCB staff is delegated responsibility to develop templates and metrics and set deadlines for this reporting. 3, within 14 days of receipt, Aledade shall provide the GMCB and the Office of the Healthcare Advocate a copy of any pre-termination notice from CMS, including but not limited to a warning regarding non-compliance with shared savings program requirements, a request for corrective action plan, or a notice of a special monitoring plan. Aledade shall additionally provide any follow-up communications from the ACO and CMS regarding the pre-termination action at the discretion of the GMCB and with authority delegated to GMCB's Health Policy Project Director. 4, within 14 days of receipt, Aledade shall provide the GMCB and the Office of the Healthcare Advocate notice of any legal action taken against the ACO or its parent company. Aledade shall additionally provide any additional information at the discretion of the GMCB and with authority delegated to GMCB's Health Policy Project Director. 5. This is one that is specific to Aledade, but has appeared in both Lore and Vitalize's budget orders in previous years. A representative from Aledade must engage in an orientation led by Blueprint for Health within the first quarter of 2025. And 6, you have your standing condition that says that the board may make further orders as necessary. And here is the suggested motion language for Aledade's FY25 budget.
Thank you, Michelle. I can go ahead and make the motion. I move that the GMCB approve Aledade's Accountable Care 205's FY25 budget as submitted, subject to the proposed conditions reviewed by the board today.
Second.
Open it up to any board questions, comments. Any questions, comments from the public? Hearing none. Good afternoon, Walter.
Hey, Tom, how are you?
I'm good, sir. It's nice to see you.
I'm looking here at a lawsuit against Aledade in March of 2024 for upcoding Medicare fraud. Do we really need these people in Vermont?
Michelle, is that, are you familiar with that proceeding? Is that within Vermont, or is that a different part of their organization?
It is external to Vermont, and Aledade did disclose.
Yeah.
I don't have at my fingertips the details, but we were aware of it.
Do we really need them in Vermont?
It's good.
I'm happy to do a brief public education on this one, Member Walsh, if you'd like.
Thank you, Mark.
Yeah, it's a great question. Starting point is just for that item, I believe there was an August 15th public notice from Aledade that those coding allegations were dismissed. But I'll step back and answer the question more broadly, which is, what is the board voting on today, and what authorities does the board have? So the board is tasked with approving or modifying budgets of ACOs that are operating in Vermont. The board under statute does not have like certification authority over ACOs that are not accepting payments from Medicaid or commercial insurance. And what that means is that the board is not in a position to approve or deny certification to operate in the state. So the budget review and approval or modification is about the budget of the ACO and any conditions tied to that budget. So just wanted to kind of set the framework for what's getting voted on right now. But there is some information about that lawsuit, I believe, in the Aledade budget narrative, which is on our website under the FY25 ACO filings. And the information in there is recent as of, I think, October. So worth checking that out if you have any questions about that.
Thank you, Mark. Any further public comment? Hearing none, are we ready to vote? Okay. All those in favor say aye.
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 And the motion passes unanimously. Thank you, Michelle, for all the hard work. Excellent presentation. Believe that concludes our agenda items for this afternoon. Have I missed any opportunity for public comment or any comment from the HCA?
Nothing from us, Member Walsh. Thanks. Appreciate it. We support the motions.
Okay. Thank you, Sam. Right. Is there a motion to adjourn?
So moved.
And is there a second?
Second.
All
Second.
those in favor say aye,
Aye.
Aye.
and the motion carries. We are adjourned. Thank you. Have a good rest of the day.
Thanks.